people viewed this post, and it was an outpour of supporting love and condolences to the families. In addition, after she passed away, I received a phone call from her daughter. Her daughter Michelle called me and shared her story. She asked that all proceeds from her mother's for this funeral go towards the foundation, which helped us raise money for this event today. So we miss her, but I want to have a chance for her daughter to come up and tell her story, so we know more about Cheryl, who we never got to meet, who would have been here today with us.
Hi, I'm Michelle Snyder Eubank. I'm Tracy Snyder Parker.
And I'm Amy Snyder Hip.
And we just want to thank y'all so much for allowing us to be here today to share with you a little about our mom, Cheryl Newman Snyder. As most of you are aware, she passed away from some complications from tracheal stenosis in November of 2015. All right, we wanted to start by sharing with you a little bit about who our mom was and the impact that she made on our lives. In preparation for a slideshow that we had for her memorial service, we were asked to gather approximately 40 to 45 photos. And as my sister and I were choosing these photos to use, we realized how difficult this task was going to be. And my mother loved taking photos and had over 65 photo albums that we could locate in their house. And there could even be more. These albums were in chronological order and complete with names, descriptions for each photo. We found her wedding album, our baby books, photo albums from grandchildren, photo albums for Colorado vacations, for our cheerleading events, for our weddings, and from Christmases past. And our childhood was captured in pictures perfectly for us to see years later. And so I came to the realization, how can you sum up your mother's life in just 45 photos? Our mother, Cheryl Snyder, lived a full life. Cheryl Snyder was not a sitter. Cheryl Snyder was a doer. She did everything full out. She gave 110% to everything she committed to. And she was always doing something meaningful, whether it be cooking meals from scratch, gardening, hostessing grandma camp, or organizing a festive holiday gathering. She was even known to make my dad run and walk a 5K or a 10K with her. She was in better shape than we were. In her elementary school days, she was a PTA volunteer and a room mom. She encouraged us to try extracurricular activities like gymnastics, ballet, piano, Girl Scouts, choir, and baton twirling. She signed us up for educational classes at the Science Museum, and she even made us complete math worksheets in the summer to maintain our math skills. In our junior high and high school days, she was a supportive cheer mom, but not a stage mom. She took turns hostessing dinners with other cheer moms before football games where all the cheerleaders would gather. Her homemade chicken nuggets, pigs in a blanket, and chocolate chip cookies were the talk of the cheerleading teams. My mom also encouraged us to be ourselves and to be individuals, even if it meant being different. Like most children, I had a favorite blanket. Unlike most children, I rolled mine up diagonally and claimed it was a snake named Tutu. And she let me do it and did not discourage me even though I did things differently. With all that being said, it shows that our mom committed her time to her family and friends in every way possible. I know I speak for the three of us girls when I say we can only hope to honor our mom and the legacy she has left by putting 110% into all that we do and to all that we are. Cheryl Snyder, our mom, set standards high, but gave us the tools we needed to accomplish our dreams. She didn't ask, are you going to college? She said, where are you going to college? She didn't ask, are you taking the SAT and the ACT? She said, I signed you up for the SAT and ACT, and here is the Princeton Review Manual. When I got engaged, I knew I didn't have to hire a wedding planner because I had Cheryl Snyder as my mom. She created an amazing, detailed Excel spreadsheet complete with formulas so that we could keep track of the wedding tasks. My mom believed in giving back to others. One Christmas, we filled shoe boxes to send to those less fortunate in Mexico. And in 4th grade, my parents' Sunday school class found out that a family from Haiti who was attending our church had no food in their pantry. My mom and dad drove us to Houston's inner city to pick up this beautiful family and give them a ride to church, and then with their Sunday school class, helped provide food for them. My mom signed me up for Junior Forum, which is a volunteer organization for high school kids. women, or girls, during my senior year of high school, where I volunteered with children and in a food pantry. My mom believed in us, she was there for us, she loved us. But my mom didn't just say she loved us, she showed us that she loved us. Family was important to her, and she showed us that family was important to her. She was there for my children's birthdays, she was there when I had surgeries, she was there when I needed advice on cooking my first turkey in the Thanksgiving of 2014. Dr. Maya Angelou said, "My mission in life is not merely to survive, but to thrive, and to do so with some passion, some compassion, some humor, and some style." Cheryl Snyder didn't just stand on the sidelines and watch life go by. She jumped in and took every opportunity to experience life to its fullest.
Like many of you, Mom was misdiagnosed for many years. Overall, she was really healthy. In 1982, when we were small girls, she had a severe case of pneumonia and pleurisy that lasted most of the summer. Mom didn't have breathing issues until April 1999, when she had another case of pneumonia. A suburban doctor diagnosed her with asthma, gave her medication, and sent her on her way. The meds did not help at all. At that time, I had just started to work as an operating room nurse at a trauma center hospital in Houston, Texas. After listening to her breathing, I had her go to an ENT that I worked with. He found out that she had a tumor in her trachea and scheduled her for immediate surgery on November 16, 1999. Her tracheal opening was only 3 millimeters, and she was required to have a tracheostomy to remove the tumor. The pathology showed a benign myofibroblastic tumor. About 50 pathologists looked at her specimen in the medical center. Even a world-renowned pathologist happened to be in town to look at it. But the tissue was so rare, and no one knew anything about it. A few weeks later, Mom was rushed to the emergency room for surgical removal of a mucus plug. The trach was removed a couple months later. The following year, Mom had a removal of scar tissue. Ironically, at the same time, she started getting treated for hypothyroidism. A pattern started. Every few years, she would have to have surgery to remove scar tissue. Mom became more and more sensitive to foods and medications. She discovered she had a sensitivity to the neurotoxin MSG and all of its derivatives. As a result of eating something with MSG, she would be sick for 24 hours with a headache, vomiting, diarrhea. Food became a stressor, and she learned it was hard to eat something from a restaurant. In 2007, Mom experienced severe eye pain. She woke up one morning with stabbing eye pain and was extremely sensitive to light. She was diagnosed with uveitis. Thankfully, that went away quickly, but it was scary nonetheless. Mom also experienced vocal cord paralysis and severe urinary tract infections. She tested negative for Wegener's several times. The breathing issues continued. She was not officially diagnosed with idiopathic tracheal stenosis until 2009. The new doctor questioned the fact that she ever had a tumor. Mom continued with maintenance dilation surgeries about once a year. The last one occurred in July 2015. Because Mom had had a terrible reaction to what she thought was the steroid, the surgeon chose not to inject Mom intraoperatively. In hindsight, we thought that made a huge difference. In August 2015, we took our last annual family vacation to Estes Park, Colorado. She hiked and enjoyed the mountains with our dad, us 3 girls, our husbands, and 6 grandchildren. Shortly after we arrived home, in early September, we noticed her breathing was bad again. What? It had only been 2 months since surgery. Mom was discouraged and mad. Surgery was temporary. She wanted to know what was the cause of this disease. Her breathing would fluctuate with allergies, colds, and who knows what. Every day was different. She lost a lot of weight. She knew she needed surgery again. Almost 10 days before she died, Mom called to get her appointment moved up. Mom asked for an antibiotic. They were slow to call in a prescription. After several more days and a couple more phone calls to the nurse, Mom finally had an appointment scheduled for Tuesday and surgery for Wednesday. Mom was convinced she could make it. She sat all weekend. She hated to sit. If you're not a sitter, you know what I mean. On November 16, 2015, after midnight, she woke up our dad. They had to go to the ER. He went to move the car, and as he walked back in, he saw her slowly collapse to the floor. Our sweet dad performed CPR and called 911. EMS arrived 7 minutes later. They struggled to intubate her and finally stabilized her after 20 minutes. Although they transferred her to a small suburban hospital, the one she said she would never go to, she was already gone. Psalm 139:16. All the days ordained for me were written in your book before one of them came to be. Our mom's death was sudden and tragic to us, but it was not sudden to our God. He has a plan, and it is purposeful. All the details of her life and death were ordained by him. Throughout this whole entire ordeal, God has been there, and we felt his presence and peace. After a few days of saying goodbye at the hospital, we returned to my parents' house to make arrangements. As I walked in the back door, I saw my little red ice chest lined up in the back hallway. This was not unusual. Normally when my mom had something to give back to us girls, she lined it up along the hallway. I immediately opened it and saw my clean food containers from the food I cooked for my parents, but I also saw a black composition journal book. As I opened it, I realized it was my mom's detailed medical history, organized into sections that she had just rewritten. Every doctor appointment, every surgery, every medication was carefully recorded in this book. After questioning my dad, he said that this is where she had collapsed. Mom was taking her medical book to the ER. I still don't know exactly how it got into my ice chest. The following day, I was talking to my uncle about my mom's initial surgery. He asked for the specific date. Since I had mom's medical book, I flipped to that section. I could look it up. 11/16/1999. Then I remembered the night before that surgery in 1999. We were fearful of the word tumor. My sister Michelle and I were on our knees crying out to the Lord. We were begging for him to give us more time with her. He did. 16 years to the day. Our mom collapsed 11/16/2015.
And now for the final part of our presentation. We're here in memory of my mother to share about her tracheal stenosis journey and her life. Throughout our lives, our mom has guided us with her wisdom and pieces of information. And so we thought that if our mother could speak to you today, what would she want to tell you? So now we present 7 tracheal stenosis tips from Cheryl Newman-Snyder. Number 1, be your own advocate. Be persistent with your medical professionals. If you aren't happy with the physician you are seeing, get a second opinion or even a third. You know your body best. Also, if your body isn't functioning in an acceptable way, call your nurse or doctor, go to their office, or show up to the ER. Number 2, find a support group. Our mother refused to join Facebook. She was like, that is not me, not about that, until she realized that there were 2 support groups, at least in particular, Tracheal Stenosis Foundation, and then Living with Idiopathic Subglottal Tracheal Stenosis, that had Facebook pages. These groups brought great comfort to her and allowed her to realize that she was not alone. So if you're not on Facebook, get on Facebook, but if you're not about Facebook, just see if you can join some sort of support group, like maybe even like a rare disease support group or something.
Number 3, educate. Many medical professionals, including my own high-risk OB-GYN, knew little about this disease. We can change that. The more attention this disease gets, the more questions it will raise. I'm a stay-at-home mom of 4 children who I homeschool. What can I do? Well, lo and behold, as I was driving in my car the other day with my 4 kiddos strapped in the back, we came to a stoplight. About 10 paramedics and firemen were doing their Fill the Boot campaign for MS. I was able to talk to them about tracheal stenosis for about 5-10 minutes. The light would turn green and I would stay there still talking to them.
Number 4, prioritize your time. Spend time doing the things in life that are important to you and make you happy. My mom chose to spend her time with family and friends.
Have an emergency plan. Our mom had the worst case scenario. Although it is unspeakable, you need to have an emergency plan. Register with 911. Call up your county's EMS provider and let them know your requirements. Not all EMTs can perform a tracheostomy. The city of Houston does not even train the average paramedic to do a trach. They think that they can get you to a suburban hospital fast enough. Rural EMTs are able to do much more advanced procedures. Talk with your spouse or partner, have them get trained in CPR, make sure they know how fragile and small your trachea can get. Wear a medical ID bracelet. If you live alone, wear a medical alert button. And lastly, if you're having a hard time breathing, call your surgeon and go to the ER. Be assertive.
Number 6, healthy eating. We believe our mom was able to live an active lifestyle despite her tracheal stenosis because she had a healthy lifestyle. She ate lots of organic fruits and vegetables and protein and limited her dairy and other processed foods. She made delicious food from scratch that nourished her body. She would work out every Tuesday and Thursday, and she actually used her treadmill to work out instead of just hanging clothes on it. She enjoyed walking and hiking in Colorado and always encouraged us to also work out and eat healthy.
In closing, number 7, God has a plan. Your life has a purpose, and as long as we are breathing, we have an opportunity to fulfill that purpose. Thank you.
Okay. I want to thank them for sharing their story, God. Okay, so afterwards, I know you guys know there's a focus group. The focus groups will, the patients will have a chance to talk amongst each other. But then there's also going to be a group for families and friends. So you guys like this, Tracy, Amy, and Michelle. The husbands, the daughters, the families, kids, you live with this. You watch us go through these breathing problems. You watch us have mucus plugs. You watch us struggle to breathe and struggle to talk. So you have your own stories to tell as well. So while we're in focus groups the last hour, the families and friends will be in a separate group that'll be led as well. So I want you to share your stories and get to know one another and share what works, how you cope with it. Last, I'm introducing Dr. Lorenz. Dr. Lorenz, I think everybody knows him already. So we all. He's going to do his presentation. Dr. Lorenz, please come up from Cleveland Clinic, and we'll have some questions afterwards, and then we'll break into our focus groups after.
It's perfect. Good afternoon, everybody. I just want to start with a little bit of thanks. Thank you to the foundation, in case for inviting me. It's really impressive to see everybody here today. And I also want to give a little thanks to the people who preceded me back in Cleveland. Some of you may know them. Some names like Isaac Eliashar or Haki Eliashar. He's a doctor. He's actually from Israel. And they had a lot of trauma during the wars of Israel. And so he got very used to airway disease, developed a large practice. Some of you may have actually had an Eliashar stent in, possibly. And then when he retired, I'd been at the clinic for about 20 years, and that's why one of the reasons I have a large practice. Another one was some doctors from rheumatology. Some of you may have heard of Gary Hoffman or Carol Langford, and they have spawned a whole group of rheumatologists in Cleveland. And because of that, we've gotten a lot of Wegener's patients. And then I had a boss named Marshall Strom. Some of you may have heard of him. He's done a lot of airway work. He did the world's first successful larynx transplant back in 1998. And I can talk about that some other time. But he also garnered a lot of people to come. And because of those people, a lot of airway patients came to Cleveland, and that's why I've inherited a large practice. I want to say thank you also to Alex and Chris. A lot of people ask, like, why haven't we fixed this problem yet? Why is this taking so long? Well, one of the reasons is we didn't have a group like you. Often patients will be the biggest instigators to get things done and get things solved. So I think now that you're all organized and you're communicating with each other, I think that the developments of the field are going to move much faster. And quite frankly, being in that field for 20 years, there's really never been an Alex and Chris combination of relatively young people with a tremendous amount of energy and the ability to fit into their schedule the research in this disease. So I'm quite hopeful that actually we're going to solve some of these problems relatively quickly now that you're organized and we have leaders like themselves in the field looking at the actual research in this. And then lastly, we just thank some specific patients in the audience who've entrusted me with their care, because what happened was developing with some people overseas, came up with an idea And these folks were very brave to say, it makes sense, and I'm willing to undergo it. And I'm going to demonstrate some results today, but without people's bravery to take that leap of faith, I don't think the field is going to advance forward. And I just want to say publicly thank you to them for entrusting me with their care. It's meant a lot. And I think it will actually benefit anybody in the audience that they've been so brave in going through that. So I've got about 45 minutes, and I'm going to take you through some new developments in the field. And I know that there's a lot of people very knowledgeable in this field, and I'm going to start with a little bit of the basics just because it really answers some of the questions that you all have. Should I have dilations? Do I need to go visit somebody if I'm feeling well? When should you move on to a bigger surgery? And my own philosophy about this disease stems from some of the basics, and then we can get to a lot of those answers at the end. So here we go. Can you advance the slides? Or this clicker's not moving me forward, so it may not be hooked up to the, but you have to run the videos too, though. And I'm going to hold the questions to the end, and I'll be around for a couple hours later so people have got specific questions. So the cause, the endoscopic treatment, the open surgery, and then a couple of new procedures I know that people are quite interested in. Go ahead and do the next slide. So go ahead to the next slide. Thanks. So why this is a very basic slide. I know a lot of people know this, but most people in the audience have got one of three reasons to have airway stenosis. Either they've got an autoimmune disease, or it's idiopathic, and a lot of people in the audience are idiopathic, or they're traumatic. Now, my thought is the following, and that is, when I was a resident, we did some experiments with animals, and what we did is we just took their airway, we just made an injury 360 degrees, and guess what? That airway that happened looked a lot like a lot of people's airway in the audience, okay? The body hates a hole. If you would make a hole in your skin, the body tries to close that down. And you will have a devil of a time trying to stop the body from doing that, okay? So my thought is, with idiopathic airway stenosis, the body's injury, the initial insulting injury, we don't actually see. I've asked multiple people, even in the room, who've got idiopathic stenosis, did you have a cold? Did you have a really sore throat? Like, did you feel like something went wrong before you actually knew you had subglossal stenosis? And the answer invariably is no, I was doing fine, and all of a sudden I started getting progressively shorter breath. I was misdiagnosed for months or years. I was treated as asthma. But I say, but was there anything before that? And invariably the answer is no. So I really feel as if the initial insult is silent, and we don't see it. You know, the body somehow reacts to either a pathogen in the environment or an allergen in the environment, and then it goes away, and then simply what the body's doing is it's trying to heal itself. And again, if you go back to those Aramo experiments we did, we just injured. We just took a cautery, we just injured in 360 degrees, and the body tried to close it down. And then we did all kinds of things. We injected with steroid, and we tried systemic medications, and we did resections and so on. But the basic nidus of the disease, that initial inflammation, that caused this airway stenosis. And then the question is, well, why can't you just make it better by dilating it? Well, when you dilate something, you're really causing another injury, right? You have to rip it apart, or you've got to cut it, you've got to do something like that. And again, the body doesn't like that. The body tries to heal it down. So my own treatment philosophy is that after that initial insult, basically what we're trying to do is stop the body from trying to heal itself over and over and over again. And that gets into how we treat it, how often we treat it, when we move to open surgery, if you believe that that initial insult is gone. Now, for patients with autoimmune disease, really, again, the body's got an inflammatory session where it occurs, and then people figure out that let's say they've got Wegener's, which is now known as polyangiitis granulomatosis, GPA, granulomatosis polyangiitis. Again, if you're in an inflammatory stage, that is a time where you can respond to systemic medications, right? And whether it be rituximab or prednisone or other medications. And I feel as if that's the best treatment during that time. But subsequent to that, people will be in remission from their Wegener's disease for years, and they'll be bothered by recurrences of subglottic stenosis coming again. And again, I think that the body is basically healing that initial injury even when their Wegener's disease is in remission. And then on the traumatic side, again, same kind of thing, whether it be a tracheotomy or actually a trauma for an endotracheal tube or actual external trauma. Again, you cause an injury, and then the doctor opens it up, and then 6 months, a year, or 2 years later, the body starts to close that back down. So I spent some time on this slide to say that I think a lot of what we're trying to do with this disease is we're trying to stop the body from its normal healing process. And that's going to go to answer a lot of the questions that people have as far as how does that matter to me? What should I have done? How often should I have it done? Do you want to go next slide? So just so we're all on the same wavelength, can you just run that video? You guys have a video over there? You do. Good. So I'm mostly going to talk about subglottic stenosis because when you start to involve, can you go ahead and play that? Play it all the way through. If it hasn't played through, you can play it again. If you go down to the bottom, just run the cursor on the bottom, and there'll be this little bar that shows up down here. And then you press it. And then you press it. Not me. Yeah, if you run over it with your cursor, you should see it. Oh, you got to see this slide. We've got about 5 or 6 videos, and you probably want to have people see them. That one's not. Like, can you? I'm going to keep talking while I bring up these videos. So I just want to make sure everybody knows that we're talking about mostly idiopathic subglottic stenosis or subglottic stenosis from autoimmune disease. We're not talking about glottic stenosis. Chris did a great job of explaining how you want to try to avoid getting your glottis involved. Some people will present with the glottic or the vocal cord impairment. That's a completely different problem. And those very fragile joints between the cricoid and the arytenoids, once you start to scar those joints, it's very hard to get them unscarred. So the split operation that he showed with the rib, I've done that before. The anterior part where you augment the larynx, try to avoid getting your vocal cords involved. Supraglottic stenosis is extremely rare, usually pemphigoid, pemphigus, sometimes autoimmune disease, other problems. Again, very much more challenging than subglottic stenosis. And then tracheal stenosis most commonly is not due to either autoimmune disease or idiopathic. It's usually due to trauma, to either a tracheotomy or an endotracheal tube cuff that's down there or some other cause. So what I'm going to talk about mostly is specific to subglottic stenosis because it's relatively straightforward. And when we talk about these newfangled procedures that are coming out, they're really being restricted to patients who only have subglottic stenosis. They're really not apropos for areas that are outside that. I'll tell you what, try to go to the next slide, and then if you can do that. I do about, I'd say, on average, about 1 cricotracheal resection a month, so maybe about 10 a year, and probably do about 20 dilations a month. And then these new procedures that we'll talk about today have just started really at the end of 2015. There's a dual force in the community moving forward these new procedures. Here we go. So just so everybody is aware, so here's your vocal cords significantly up above. That's the cricoid cartilage right here, right in the middle. And then the trachea is down below. So we're just talking about subglottic stenosis. So I mentioned in that first slide what the cause is. If the Wegener's disease is in remission, you can still have the body try to heal the subglottis. If the trachea is involved, that's a completely different disease because you really do well with a resection by itself. And when the vocal cords are involved, that's also something separate. So we're really going to talk mostly about subglottic stenosis today. You can go to the next slide now. That's the same one. So I think people have seen this before. On the right is the subglottic stenosis that's not involving the vocal cords. On the left is after we've actually treated it. Now it looks pretty rough, right? To go back to that initial statement, we try to do as little to the subglottis as possible when we open somebody up. So my standard treatment now is to inject steroids. And you say, why inject steroids? Remember that idea of stopping the body's own healing process? Fibroblasts are the cells that lay down scar tissue. And the body's trying to heal itself. And we know that steroids inhibit fibroblast activity. So a lot of people in the audience will get just dilation, or they might get dilation plus mitomycin, for example. But again, in my mind, the steroids are important because they stop the body from trying to heal itself. Now, there's some doctors in the country, in the US at least, who are actually doing only steroid injection. They're not doing any dilation, they're not doing anything cutting, all they're doing is steroid injection, and some people are doing it awake in the audience. The reason is you can avoid going to the operating room. So they'll literally have the patient awake in the audience, in the office, they'll insert a needle, and they'll inject steroid directly into the stenosis. It's not a bad idea. I don't think the results are out yet to say that that should be the next wave of treatment that occurs, but if it is, that would be pretty good, right? No endoscopy in the OR, no trauma, simply an injection of steroid. You know, I liken subglottic stenosis a lot of times to a keloid. A keloid, you might see some people, especially if they've got darker pigmented skin and they get their ear pierced or they have an incision somewhere, they'll get this almost like cauliflower response to the body healing. And the way you treat a keloid is you don't cut it off, it'll just happen again. You actually inject it with steroid. Very similar kind of idea to the subglottis. Okay? Let's talk a little bit about mitomycin, because a lot of people have had mitomycin in the audience, and I used to use mitomycin. It seems as if the studies that were really well designed, where they hung a bag in the operating room, and they had either mitomycin in it or they had saline, and nobody in the operating room knew which one was which. It turns out that the people who got the saline did similarly well as to the people who got the mitomycin. The mitomycin didn't seem to make that much of a response. Now, their scarring happened later, so it seemed to delay the subsequent scarring, but didn't stop the subsequent scarring. There is some downside with mitomycin, and that is in an animal model, when you use it at high dose and you use it repetitively, it's actually shown to possibly get tumors. But that's in an animal model, it's with very high dose, and it's with constant dose. So I don't think there's any reports of it ever causing any tumors in people, but it is a chemotherapeutic agent, and we should just use it with caution, okay? So I'm not saying don't use it, I'm not saying people who use it are wrong. We know that it delays healing, or delays the scarring. That being said, I don't use it myself. Let's talk about laser for just a second. So some people will make cuts with laser, other people will use cuts with scissors. We actually did a study in which we looked to see which one delays scarring reformation and which one actually gets people into remission where they don't need any more dilations. The thought process is this: either one is good. Obviously the laser doesn't have as much bleeding afterwards, but the laser, when you cut with a laser, not only do you make a cut, you actually have a little bit of a zone of injury outside of that cut. In other words, you actually heat up the tissue on both sides of your cut. When you use something like with a scissor or a knife, you just basically just cut right there. And again, we talked about how you're trying to do as little trauma as possible, because the more you do, the more you just inspire the body to heal it. So if you make a small cut right there with your scissor, it may be better than making a larger cut with a laser. Again, I'm not saying that laser is wrong. I've used lasers hundreds of times. I'm just saying in my own philosophy, the less trauma you can do to the voice box, probably the more likely you can get somebody into remission. In other words, not need any more surgeries and not need them as close together. So again, to go back to the first slide, again, I think the etiology, I'm trying to get back to the etiology of the disease, trying to stop the body from healing itself, that steers us towards steroids, steers us towards less trauma, and also steers us towards less frequent dilations. So people often say, should I have a prophylactic dilation? You know, should I do it no matter what? And there's some doctors who are doing trials right now that say, listen, let's do this every 6 weeks, whether you feel like you need it or not. And that way we can just get your body over this healing process. We can just kind of get you over the top. I don't think it's a bad idea. It's not what I do. I try to do as few interventions as possible. And now people will say, well, how many interventions should I have before I have a big operation? Very astute comments by Alex and Chris previously. You don't want your glottis, your vocal cords, involved in the disease. So over time, if you're getting upwards of 6, 7, 10, I had somebody come up from Texas who had 40 dilations, you're really possibly traumatizing the cricoarytenoid joints, those joints right in the back there where the vocal cords meet the cricoid. And I tell people, you can have as many dilations as you need. I just caution you that if you start to involve the vocal cords, it's a whole different ballgame, and try to avoid that situation. Go to the next slide. So this is just for people who aren't knowledgeable as far as the steroid. Go ahead and play the video. What we do is you try to actually just get the tip of the needle directly in the scar tissue and inject it submucosally. Get it to track right in that, just like you would a keloid, and get the steroid to deposit itself right in the scar tissue. And the thought is you can avoid pill steroids like prednisone, but you can get a high dose of steroid directly in that area. Let me just get through it. I'll answer all the questions at the end. And again, the concept of these people doing this in the office, what they're doing is they're going from the outside, sticking the needle right in this site that you just saw, and depositing the steroid right in that area. They might say, well, if that was the answer, then I wouldn't need repeated dilations. Yes, but the studies back in the 1990s by, again, Dr. Hoffman, a guy named Bob Lebovitz in New York, who's an excellent otolaryngologist from Carol Langford, what they were doing is they were treating patients with Wegener's disease and subglottic stenosis, so it's not apropos for all the different causes, but what they had was, before they started injecting steroids, 50% of the people ultimately required a tracheotomy before they were injecting steroids. After they started injecting steroids, 0% of the people needed a tracheotomy. So it seemed to really make a difference there. Can you go to the next slide? Here's our own published data. So what you see is that for patients who got steroid injection, their time interval in terms of years to the next dilation was significantly longer, almost reaching the p-value of significance. We looked at whether or not they used cold nice or CO2 laser, whether or not you had mitomycin, and then whether or not you used a bougie or a balloon. I'm going to get to that in just a second for those of you who are not familiar with the bougie. I think that's a very important advance that the field has made in using balloons. I'm a strong proponent of balloons over what's called the bougie system. But again, what you're seeing is that steroids seem to make the difference and push people out from not only having fewer dilations, but having greater intervals between dilations. Go to the next slide. Dr. Sandhu in the UK also showed something very similar. And go ahead and play this video. So why do we make cuts at all? Why don't we just dilate by itself? And what you're going to see is, so you make cuts. These are like little radial cuts. If you make 3 of them, it almost looks like a Mercedes sign. If you make 4 of them, you make them the 4 quadrants. And then comes the balloon, and the balloon then expands that area. So I've been practicing for about 20 years before we had these balloons. And what we would do is we would push down what's called a bougie. And a bougie is simply something that starts small and then gets much bigger. The problem with that is that as you go past the vocal cords, you can really injure the area between the vocal cords called the intrarytenoid space. You guys are seeing all this, great. Once you injure that space, it's all over as far as your glottis goes. Then you're into glottic stenosis. The balloons allow you to treat the subglottis without damaging the vocal cords. So I would caution anybody in the audience to use the old-fashioned sounds or the bougies and really move on to the balloons. Before recently, we had these balloons that were kind of like the balloons that you blow up at a party. They just get bigger and bigger in all dimensions. Now we have something called radial controlled expansion. What that does is, as you can see from this balloon, it's rock hard, but it doesn't keep expanding. It expands to a certain limit and then it stops. In the old days, it would kind of, you know, if you pushed here, it would balloon out over there, and then it could be pushing on all kinds of structures that you didn't want it to push on. These radial controlled expansion balloons are much safer. And then there's a gentleman down in Cincinnati who has developed a new balloon, which I think is going to be a great idea, Mike Rutter. And what he does is the balloon has almost got like a little ridge at the top and on the bottom. And as a surgeon, what happens is if you start to inflate these balloons, they do something called watermelon seed. So they'll pop out towards you or pop away from you, because it wants to kind of, as you can, like a watermelon seed, it wants to kind of go to where the resistance is the least. With these little ridges, it kind of locks the balloon in place and really just limits your expansion right to that one site. So I think that that type of balloon is going to become standard over time. I do caution people in the audience, if you're here for what's called tracheal stenosis, you have to be very gentle with the trachea, because the cricoid is a circumferential cartilaginous ring, right? It's a ring in 360 degrees. The trachea is just a U shape. And if you would stick a balloon in a very tight stenosis of the trachea, unfortunately you can possibly rip the back of the trachea. It's a muscle called the trachealis. And once you start to rip that muscle in the trachealis, it can extend down into the chest and really extend far. And then you have a hole in your trachea, which is a huge deal. It's actually a life-threatening problem. So balloons are quite safe in the subglottis. And if someone's going to use it in the trachea, you've got to be very, very cognizant that you have to limit the size of the balloon and limit the pressure of the balloon so you don't rip the trachea apart. You go next slide. So this is a schematic of what's called the cricotracheal resection. Before the new procedures that we had, the cricotracheal resection was the go-to procedure for patients who were not getting relief from endoscopic therapy. And what it did was it basically removed all of the diseased cartilage and the diseased mucosa on the inside. And as you can see, what you're going to do is you're going to resect the cricoid anteriorly, resect any of the trachea that's involved, and then you create this little flap right back there. And that flap is going to sit on the back wall of the cricoid plate, this little flap right back here. And what you do is you remove everything, and you remove that back of the cricoid plate right down to the cartilage. And then you take that flap and you put it right in the back of the cricoid, and then you hike the rest of the trachea up and you stick it right to the thyroid cartilage. The cricoid cartilage in the front is gone. You hit that, you just actually take that trachea in the front, you hit it right up to the front of the thyroid cartilage. It's a good operation, and that operation, so far I've actually had 100% success. The only person that wasn't successful was somebody who smoked after the operation. Never smoke if you've got any kind of airway disease, but never do it after an operation, obviously. So it's a very, very safe, it's a very effective operation. The problem is it's a big operation, right? In order to get the airway to stretch that much, you've got to go way down into the chest, right past the aorta, next to the heart, to free up the trachea to get it to be mobilized enough. So that's pretty risky, right? Number two is you remove the front part of the cricoid cartilage. And the front part of the cricoid cartilage attaches to a little muscle called the cricothyroid muscle. And unfortunately, the majority of the people in the audience are women, and women have beautiful, nice, high frequencies to their voice. When you remove that muscle, you definitively drop your what's called fundamental frequency, the voice that you speak with, you drop that. And it's just not an attractive voice for a woman to have that drop. And also you lose inflection of your voice. So, you know, the expression that we have, how are you? I'm fine. Those kind of things are much harder after you've lost that cricothyroid muscle. And you automatically do that when you remove the anterior half of the cricoid. And then lastly, there are those things called the recurrent laryngeal nerves, those little white or yellow things right on the side of the diagram. They're very, very close to your cricoid cartilage, so you put those nerves at risk. It's all scar, mostly in people who've had tracheotomies and all kinds of airway problems. So it's very hard to find those nerves, and if those nerves are injured, you'll have a vocal cord paralysis in addition to having subglottic stenosis, another new problem you don't want to have. Who is this operation really good for? Patients with long stenosis. So patients with very, very short web-like stenosis, they tend to respond very nicely to endoscopic treatment. Patients with these kind of long tunnels instead of a short little web, those are patients who don't do as well from endoscopic therapy because it's hard to, when you push that stuff out of the way, it just kind of comes right back, right? It's kind of like pushing the sides and walls of a tunnel out of the way. And over time, it just kind of, the body tries to heal itself and kind of grow back in. So that is a good patient for this operation. And patients who've got both tracheal involvement and subglottic involvement, those patients will respond nicely to this operation as well. Who doesn't do well? Patients who've got diabetes, okay, they have usually problems with healing. Patients who've had a recent tracheotomy, they have a lot of inflammation in their airways recently. And then patients who are on high dose of immunosuppressants like steroids, you have to be very cautious with that because they don't heal very well. So those are, and then also patients with COPD. Not many patients with stenosis have COPD, but those who do, you have to be wary of that as well. So COPD, diabetes, steroids, those are all problematic. Sometimes after this operation, you'll need a temporary tracheotomy below the site of the anastomosis. The anastomosis is where you put things back together. And that tracheotomy is put in there just so you can get through the perioperative period and heal well and then get the trach out. Because kind of a nightmare scenario is you put somebody back together and then things start to fall apart, and that's very dangerous. So sometimes you'll need a temporary tracheotomy right in the immediate postoperative period, but the whole idea is that that would come out later. So I was looking at this operation for about 15 years, and I was thinking to myself, when I remove the scar off the back of the cricoid looks pretty normal. That cartilage looks pretty normal. The cartilage itself is probably not the problem here. And I said, if we can save all the cartilage on the outside and just remove all the scar on the inside, I think we can get it so people can keep all the outside of the airway, but remove just the disease on the inside. Again, we talked about how freeing up the trachea and kind of putting things back together, that's somewhat dangerous because it could pull back apart. So you would limit that possibility of things pulling back apart if you don't shorten the airway. And then we talked about how that muscle, that cricothyroid muscle that sits on the outside of the cricoid cartilage, if you don't remove the cricoid cartilage, then you wouldn't have to remove that muscle, and therefore people wouldn't lose their pitch and lose their nice high frequency of their voice. So while I was thinking about this, I was actually overseas for a couple of years. I thought maybe we could do that. Somebody in London had almost the exact same idea, a guy named Burry Sandu. The thought was, let's remove that part of the diseased skin and leave the cartilage there. And then, so what happened was, at the same exact time, he and I developed similar type procedures that I'll show you next. Can you go forward? I call mine the Reacher procedure. I was a little bit hesitant to do all this through the mouth, because my thought was that, first of all, you've got to breathe for the whole operation for somebody through the jet ventilation system. And I was a little bit concerned about that. Plus, I was really concerned about doing a surgery kind of at 2 feet away that really was going to be, needed very, very precise motion. I wanted to be much closer to the operation. And so the Reacher, just hit the next slide, stands for retrograde. That means we're going to do this backwards and go up through the trachea and go back up towards the top of the head. So most times when you have an endoscopic procedure, you go through the mouth, you go down. This one, you're going to go through the neck and go back upwards. Kind of a unique idea. Endoscopically assisted, because we still use little endoscopes to see what we're doing. It's very, very short distance. It's only a few inches, but we still use endoscopes to make sure we're doing the right thing. Cricoid hypertrophic epithelial resection just means removing the epithelium or the skin, which is hypertrophic, from the cricoid cartilage, and we're going to remove all of it. So that's called the Reacher procedure. Can you go show the video next? So here's the schematic. You're going to see this run through this. So through the neck, we're going to open up the trachea from below. And we're not going to remove any of the tracheal rings. We're just going to open them apart. And we're also not going to open the back wall of the trachea. That's somewhat harder to heal. We're just going to spread the rings apart. During the operation, we can breathe for the patient, actually with a breathing tube, just during the operation. And then we're going to look from below. See the stenosis from below? That's all the narrowing. And we're going to take out that stenosis right down to the cricoid cartilage. And what we're going to do is place in its place a stent. Now, I know you talked about stents before. This stent's going to stay open. It's going to stay open so you can breathe through it. And then one stitch to keep it in place. Close the trachea at that exact time, and then people would end up breathing transorally after the operation. So at the same exact time, Dr. Guri Sandhu, who I've got very high regard for, said, well, why don't we just do that through the mouth? Now sometimes, because it's hard, some people don't jet ventilate very well. Their lungs just don't expand enough to get 45 minutes to an hour of breathing capacity. So for people who don't respond to jet, I think this reacher will probably be a procedure that they can have because, again, you're putting a breathing tube down temporarily. Dr. Sandhu just puts a tracheotomy in temporarily. So that's also another idea. I tend not to do that. I like to visualize from below. And then the other issue is that some people, you just can't see their subglottis. So especially people who've got like kind of larger upper teeth, or they've got a smaller jaw, just some simple anatomy, you can't actually see the subglottis very well. I think that the reacher will still have a place. But over time, and this procedure is actually named after the first patient who had it, their name was Madden, and just like I'm very thankful and very appreciative of the first patients who had the procedure that I did, Dr. Sandhu was as well, because it's just a risk. When you start out doing these operations, you just don't know if it's going to be successful or not. So in honor of that first patient, he named the procedure after her. So he's doing the exact same thing, removing all the scar tissue, replacing it with a skin graft, and then that stent comes out 2 weeks later, about 14 days later. And so I've got some slides, go ahead, some videos that I'm going to show you. So he's going to do his all through the mouth. Go ahead and play that video with the laryngoscope. And the whole operation occurs through the mouth. And I just did one of these yesterday, and it went very well. And the idea is that we're going to put this jet ventilation on there and then push air through the stenosis and do the whole operation transorally. It avoids that scar in the neck. I do place that stitch through the neck, though. Don't forget about that. That stitch has to hold the stent in place. That's critical. What are the risks with this operation? One is it doesn't work. When I say work, I'm going for no more procedures again. That's the goal here. Don't always accomplish that, but that's the goal. No more dilations, no more treatment. That's the goal. Number two is that stent could get blocked. Now, it's a very short stent. It's only about 2 centimeters. It's only about 1 inch long. And the longer the stent you have in the airway, the more risky it is. So we try to limit the length of that stent. You also don't want that stent to touch the vocal cords, because when it touches the vocal cords, it can have some vocal cord scarring. So you want to avoid that as well. Go ahead, next slide. So here is a subglottic stenosis that we're going to treat with that reacher procedure. I think everybody knows what this looks like. It's a standard subglottic stenosis, very non-inflamed, so not very red. There's no granulation tissue. It's a little bit long segment. You can see it's not short like a little web. It's a little bit long. So pretty standard. We'll go on to the next slide. And what we're going to do, as you can see, is the patient's head is up towards me on this slide. It's to your, on the bottom picture, it's to your right. And what we're doing is we're basically operating kind of up towards the head. And you can actually see on the monitor what we're doing. Go ahead with the next slide. This is the reacher operation. And this isn't too gory. It's just going to show you some of the visualization you get. So there's the stenosis. We're going up to the vocal cords. We're going retrograde. That's why it's called the retrograde, the reacher procedure. So pretty good visualization. We're only about 1 inch away with our hand to do this procedure. Very close. There's just 1 stitch holding the breathing tube from above. You go to the next slide. The next slide shows we've removed all of the narrowing, and we have the stent in place. And on the outside of the stent, you've got the skin graft, and you also have something called adaptic, which is like a little piece of Vaseline gauze. And we've got this under tight control. We can see everything very closely. And then a stitch has to go through this to be able to hold this in place. And that's what it looks like from below. So, can you go to the next slide? So it's a very short stent. It's made of silicone. Basically, we take the T-tube and cut it short. We also kind of use a Dremel drill, which is this little, like almost carpentry drill to make sure that the edge of the stent is very, very smooth. And then it's just like a thyroidectomy incision. It's a pretty standard incision, so it's not a very big scar at the end. Next slide. So this is what it looks like with the stent in place. And you can see the stitch right there across. And we're just about to cut the stitch and remove the stent. You see the trachea down below looks relatively normal. We'll talk about mucus at the end too, because the mucus is a big problem. Now, I have to be honest with you, I didn't know the critical part of this operation when I first started, and I'm going to tell people here, because if your surgeons in the future start to do this, it'd be great if you could tell them what I learned. You have to cover the stent 100% with the skin graft, because if you don't, you will get a narrowing where you don't cover the stent. And I had to learn that process, unfortunately. And so the next slide I'll show you is a result, which what you're going to see is as we go through the vocal cords, we have a little web of restenosis right at the top where I just showed you that stent. I didn't cover the stent 100% with the skin graft. And I didn't know that that was a critical thing. And as you go through, going through the next slide also, you can see that where the skin graft is, it's 100% open. It's really, really wide open. But just about 2 millimeters at the superior edge, I had a problem with restenosis. All the subsequent people after that, I knew that that was a critical part of the operation, and unfortunately, like I said, I had to learn that. Again, my goal here is no more treatment ever again, and I think that the more recent patients that have volunteered to do this, I think will achieve that. They're really doing fantastically. And I think this is not a critical problem. I think we can get through that little web. As I mentioned, little webs respond very well to steroids and dilation, so I think we'll get to a great result with this. It's just going to take more work than I had hoped for. So, go to the next page. So I'm going to show you just one other patient. This is a patient who had a trach in. I think she had about 40 dilations before we met. And you can see very, very severe subglottic stenosis, almost critical. You can say, why, how is she breathing? She has a tracheotomy in. And she was very, very interested in the Reacher procedure. And I said, you know what, let me try the Madden procedure. Let me try to do this from above, because you have a tracheotomy in. I knew she didn't respond well to jet ventilation, but she already had a trach. And so, can you play the next one? This is the way it looks from below. Here we're going through the tracheotomy, and we're going to look up above. We're going to look retrograde. This is pre-op. We're going to look up towards the vocal cords. So it's very, very, very tight, right? Can't even see the vocal cords. So we did this procedure. Now you might say, why is this better to put a skin graft up there? Like, what is it different? Again, the body tries to heal something, and what the skin graft does is it tells the body, you're healed here. You don't need to inflame this area. And that was a critical leap of faith that Dr. Sandu and I had to make, is that leaving it raw or just operating it and leaving it open, it seems like that skin graft has some kind of reaction to the underlying tissue that says to the body, don't heal me back. And so go ahead and play the next one. So this is her post-operative result. So I think we're about 2 months post-operatively on this. And what you're going to see is, we're going to look up above towards the larynx, towards the vocal cords. You see the white skin graft. And there are the vocal cords in the distance with her breathing. Or saying E, for example. So go to the next slide. So the comparison here are these two pictures. On the right is the stenosis, and on the left is the skin graft in place. And it seems like that skin graft being there is going to be the thing that really makes this procedure, possibly the standard in the future for patients with isolated, non-inflamed subglottic stenosis. Not for patients with tracheal stenosis, not for glottic problems, not for patients who've got active inflammation, but for well-healed, mature scar isolated to the subglottis. It seems as if this may be the answer for those patients to avoid further endoscopic treatment. Let me just talk about mucus for a second. There's two reasons why people have so much trouble with mucus. One is because they're narrow, and everybody makes mucus in their lungs, and it's hard to cough mucus up through a stenosis. The second problem is, after you've had either scar or procedures, you lose the cilia of the subglottis, right? So everybody who doesn't have any airway disease, the cilia is beating your tracheal secretions up. We just go like this, The secretions come above our vocal cords, we swallow them down, no big deal. For people with stenosis, they've got two problems. They're narrow and they don't have the cilia. This fixes the narrow part, right? So the mucus will not be as bad for people who have replacement with the skin graft. The problem is that you don't get the cilia back. So what Dr. Sandu is doing, which we're starting to do with one patient, is to after they're healed and they're open, so after they don't have any stenosis, going back and just gently, very, very superficially with a laser, we're not doing a full 360 degree, but just with a strip of that, what's called keratinized skin, because it comes from the outside of the body. We're doing a little strip here, a little strip here, a little strip up above, and what we're finding is that the normal cilia, respiratory epithelium starts to regrow in that area to change this from a white result to very much looking much more like normal mucosa. And we think that that's a very, I mean, that's a good problem to have, right? That you want to be in the situation where you don't have any stenosis, but you just have a problem with mucus retention because you have a skin graft in place, and then at your leisure, you can start to refine that down to get ciliated respiratory epithelium. Another possibility is we might start with some kind of engineered epithelium that has cilia within it. That would avoid the need for a skin graft, and it would avoid this post-operative appearance of this white appearance. That's another idea, but for now, just getting people so they're completely open and not having the shortness of breath is an advance in and of itself. So there's 4 patients here in the U.S. I think Dr. Sandu is up to, I think, 12 now in the U.K. I think other surgeons are starting to say, hey, if this works and we can actually get people open and they don't need any more procedures, this might be where we go. So let's see what happens. This is done under IRB approval. In other words, we have to make sure that the institution says this is the right thing to do. It's not too risky for patients. And again, I just want to thank patients who have been willing to say, I want to advance the field. I understand that's not proven, but I'm interested, and then they move forward with that trust. So the last slide is just in summary. My belief, and it's going to be very interesting if we can get Dr. Wooten and Dr. Gilbert up here to talk about the differences in our philosophies, is we're trying to heal, we're trying to reverse the body's normal healing process. And that endoscopic therapy is the mainstay. You know, there's one surgeon on the East Coast who says, don't get dilations because it ruins the possibility of having a successful, large, traditional cricottracheal resection. I don't see the evidence of that. I've done cricottracheal resections on patients with dozens and dozens of operations, and it really, yeah, it makes it a little bit more complicated, but that being said, 95% of patients will respond to endoscopic therapy. Most of the people who have this disease are not in this audience because they had 1 or 2. We average between 2 and 3 dilations before patients don't need any more dilations. Some people need 5, some people need 1, but the average is about 3 that we've published, and the same publication came out of London as well. The people who have trouble with this, who actually are highly invested in the disease, are in this room right here. They haven't responded to a few dilations, or they have more complications from the disease. So I think endoscopic therapy is likely going to stay the mainstay of treatment. And it seems like for patients who don't respond, who've got isolated subglottic stenosis, that this may be an answer for them, but you have to select the right patient. Just a word on logistics here. Some people say, well, I'm interested in that procedure. When I go and have that procedure, I learn a tremendous amount by having people asleep in the operating room. So often they'll have undiagnosed fixation to their vocal cords, but you can't pick that up in the office. You need to actually get them asleep and push on the area. Or they might have a really longer stenosis that you didn't appreciate. One patient actually I found had a tumor, didn't have stenosis at all, but had been treated for, it was a benign tumor, but had been treated with dilations. One patient had a foreign body. They were sent to me with a foreign body. We're actually publishing this, and she gave us approval to publish this. Had to have a foreign body in her trachea for 40 years. She developed it as a child, was short of breath for years and years and years, didn't know that she had it. We got some films preoperatively. She was scheduled to have a dilation in a different state. I said, something's a little funny here. Let's just take you to the operating room and see. Ended up it was a foreign body that we took out. The point is that there's a limited amount that you can do with CT scans and pictures, and getting somebody asleep to really get a great look in the operating room is worth a tremendous amount. I know it's highly, highly inconvenient for patient, but you kind of get one shot at having a good result, and you don't want to bugger that up by making things as convenient as possible. And you do the wrong operation, you really don't serve anybody for that result. So with that, I think I gave you the basics of the philosophy, and I think we've got time for questions and answers now, or is it just afterwards? Casey, now. How many minutes? Okay, 10, 15 minutes. How long does the stent stay in? The stent stays in for 14 days. And again, thank you to the people who initially went over this. I thought it could stay in for just 11, 12 days. Started to take the stent out, saw that the skin graft didn't take 100%, and kept it in there, thankfully. And so now it's about 14 days. Maybe more is better. I don't think so, actually. The more you've got that stent in place, first of all, it's risky, right? It can block off. Secondly, you can form granulation tissue at the edges. I think if you cover the stent with that skin graft like I showed, I think that will decrease the possibility of creating granulation around the skin graft. 14 days. The question is, where does the skin graft come from? I take it from the hip area in general. You know, you can cover that up on the beach, and I take a very, very thin skin graft. Skin graft is only, what we say, 13 1/1000ths of an inch thick. You can almost see through it with your eyes. I think it's important that you don't take a very, very thick skin graft. I'm thinking about going to what's called the buccal lining, because the inside of the mouth is a different kind of epithelium that probably is not as, that's more responsive to the normal airway. The problem with that is that it's very, very thick. And I like to try to get, you know, that last slide I showed of the result of the subglottis, her airway is almost more open than the normal person's airway, because we removed all of the normal layers of the skin, and we have a very, very thin piece of skin graft that's in there. So that's why I take, when we say split thickness, that doesn't mean that you have a hole in your skin. It means you just literally take a slice of the skin, a very, very thin slice, and then that heals up over time where you took it from.
And then secondary strips later
Mm-hmm. The question is, why doesn't the ciliated epithelium heal back? What you see right here, this white, that is the skin from the hip. That is the skin graft. And that skin doesn't have cilia in it. And that skin is alive. And the thought is, after you can get somebody open, then at their leisure, if they are so inclined, and if they have problems with mucus, to laser that out to get the normal cilia to come in. Now, again, I caution everybody, if you would just simply laser all the skin out, you would probably get your stenosis right back. You really want to create it so it's not circumferential, that it's a strip down this way down the airway, down this way down the airway. And again, this was Dr. Sanders' idea, and we're starting to do it here, and it's actually having some pretty nice effects. You know, how long should you wait between those procedures? Probably 3 months, maybe 6 months. Again, this is a good problem to have. You're no longer short of breath. You just wake up in the morning, have this thick glob of phlegm, you've got to go into the shower, you've got to, you well humidify, and then you've got to hack it out. Well, you know, you don't want that if you don't have to have it. So that's the idea there. One word about reflux for just a moment. A lot of people will come being told that reflux caused their disease. And one of the studies that they based that on was they took people with subglottic stenosis and looked to see how many of them had reflux. And the incidence was much, much higher in patients who've got airway stenosis that they have reflux. And the thought was, well, the reflux caused the airway disease. Well, the problem with that study is that if you took a normal person's airway and then all of a sudden you crimped it down, what are you going to do? You're going to actually have a very negative pressure in your chest, right? And that negative pressure in your chest is likely going to potentiate some kind of reflux into the esophagus. So the thought was not so much that the reflux caused the stenosis. All the people who were examined for the study already had stenosis. The possibility is that the stenosis was causing the reflux. So the question is, should everybody go on anti-reflux medication? How long should you be on medication? More and more studies are coming out that shows that years of anti-reflux medication are actually a problem for other medical conditions. So I like the idea of being on reflux medication right after an endoscopy treatment, right after a big surgery. I try to get people off of the reflux medication. That's controversial. We had one of the founders of our field, a guy named Jamie Kaufman, who years ago put everybody on very, very high dose anti-reflux medication. And I saw a lot of those patients afterwards, and they said it didn't really help me. And again, I could be wrong, and we don't know all the answers to this, but I tend not to put people on very strong anti-reflux medication for long periods of time.
Just like 3 short questions. Balloons versus rigid bronchoscope for dilation. Why do some physicians do the rigid bronchoscope?
Let me start with that one first. Question is balloons versus rigid endoscopy. And so, years ago we didn't have the balloons, and so rigid endoscopy, that's where you have what's called a bronchoscope. It's actually a long, hollow tube you can see through and you can ventilate through. And the benefits of using that are you can ventilate the patient while you're doing it, you can see what you're doing through the bronchoscope, and a lot of people have that equipment because the balloons are relatively new and they're disposable, and the bronchoscope has been around for literally 100 years because people would get foreign bodies, especially kids, into their lungs, and they had to invent this stuff early on to be able to get that stuff out. So the good news is that everybody has it, and you can ventilate through it. The bad news is that you risk injuring the voice box because you've got to push it through the voice box. Now, the argument to that is, well, the voice box is relatively big, the vocal cords are relatively big at the glottis, the stenosis is very, very small, so therefore you really don't injure the voice box. I think the balloons do a better job, but I can see how somebody might want to do rigid endoscopy instead of the balloons. That's my own treatment. The other 2 questions.
And the reacher operation is 2 steps, because first you do put the stent in and then you 14 days later go back in.
Right.
And so it's 2.
So let me just make sure, again, when I say on the reacher and the MAD procedure are basically the same procedure. It's just that one is done from below up and the other is done from the mouth down. And I think that over time, the MAD procedure, if this is going to be the answer for idiopathic subglossal stenosis or isolated subglossal stenosis, the MAD procedure is likely going to become the standard. I think the reacher will be reserved for people that you can't get down to the subglottis, or for people who can't undergo jet ventilation for an hour at a time. I think that's where the field will go, but I can't predict that. So given that they're both very similar, the reacher and the MAD procedure, both of them place a stent with a skin graft, both of them get the stent out 14 days later. The first operation is a bit long. It can be anywhere from an hour and a half to 2.5 hours. The second operation is all 10 minutes. You look down, you cut the suture, you take the stent out, and you're basically done. You might clean up a little bit. You might inject a little bit of steroids around some granulation tissue. You might take out some of the excess skin graft. You might try to clean things up, but it's a very short procedure, all done through the mouth with either procedure. But I will caution you that I think when people say it's just 2 operations, you're done, I think you, again, gain a lot if you've never met the patient by looking down yourself. Because a lot of patients will say, I'll just fly in, have that big procedure, and then be there for a while, and then fly back out. I've discovered a lot of undetected disease by getting people asleep once, getting a good look down, possibly doing the dilation at that time. And another thing that you gain is to be able to know whether you can actually do a MAD procedure. Because a lot of patients will look normal, like they have a normal airway, and you try to see their subglottis. It's incredibly difficult. For either they have a large tongue, small jaw, large teeth. It could be 100 different reasons. So getting them sleep beforehand really can tell you how hard things will be in the future. Do you have one more question?
All right, real quick. One of the reasons that you developed a different surgery was because of the voice quality of the resection.
Mm-hmm.
So is it your sense that voice therapy wouldn't be able to change that quality of voice?
No, unfortunately not. It maybe makes people better, but the ability to go, that is all that the cricothyroid muscle. And once you remove the anterior part of the cricoid, that muscle is never coming back.
So how does the skin get blood supply that you put back in there? Is that it just, I don't quite understand how that.
Yeah, the question is, how does the skin graft get blood supply? Just placing the skin with the stent and keeping the skin immobilized for 2 weeks, that will get blood supply from underneath. And that's the usual way. That if you make a very, very thick skin graft, then it's much harder because you've got a lot more skin that's got to get blood supply. But when we're talking about almost like a paper-thin type of skin, you're seeing that it does get blood supply from underneath. So a lot of people say, why don't you just avoid the stent? Because the stent is risky, right? You could get a mucus plug in that stent. Because if you don't fix that skin graft in place, people just cough it right out of their mouth. They'll cough it right out.
And then my other question was, I'm assuming it's difficult to grow endotracheal or to grow those cells on a skin graft, and it would take a really long time to take like a biopsy of someone's, and nobody's figured out how to do that.
Well, people are working on that, so that's kind of like tissue engineering. So there's specifically somebody in the UK named Marty Birchall who has worked on taking cells out of people, growing cilia and respiratory, putting them on some kind of construct, and then putting them back in the airway. So I think, in 30 years we'll be there. The question is, what do we have for today? Good idea, though.
Are other surgeons doing the Reacher or Madden procedure, or are you currently training any other people?
Well, in the U.S., because the Reacher was just my own concept, the answer is only people who saw Dr. Sandhu and I speak in Baltimore a few months ago. And let me just turn it over to the Vanderbilt guys. How do you guys feel about these new final procedures? Because these are very, very eloquent speakers who've got great experience themselves.
I think that the science makes it seem like the problem in that isolated area of skin, and it's not in the cartilage, just like your kind of observation. So taking away that skin, I think addresses the problem. The skin graft is sort of this new technique that Dr. Sandhu has, applied to ISGS that's, I think, made a big difference. That's just kept the scar from coming back. So it's something that I find a lot of faith in, and I'm pretty optimistic that it'll make a big difference. I guess my questions still are sort of the long-term outcome. What happens to that skin when it's there? Do people have a lot of trouble with that skin now? Just like you said, not working kind of like normal respiratory mucosa. But it seems like that's pretty well addressed with the different things he's doing. We use this stent and skin graft at Vanderbilt for a lot of other diseases, based on visiting with Guria and spending time, not necessarily all in the idiopathic setting, but it's something I think that'll really take off in the United States because it's a pretty accessible technique. It's something that a lot of people who are advanced endoscopists spend a lot of time doing. The same tools and techniques. It's just finding sort of a new way to apply them.
Okay, I have 3 questions, I think. One question, okay. Is there ever a time when you would have a stent put in and the stent would stay in always? Maybe without a skin graft, just a stent put in.
Yeah, so great question. People who need stents and indwelling stents for long periods of time. Stents were a standard 20, 30 years ago. A lot of people got stents. And they were all kinds of stents. They were silicone stents, they were nitinol stents, which is a kind of metal, all kinds of things. The field has really gotten away from stenting if possible. Now some people, for example, tracheal malacia or relapsing polychondritis, these are patients who really have very little structure of their airway, and a stent is a solution for them. Again, stents are very dangerous. The longer the stent, the more likely you can get a mucus plug in that stent. So the concept of having it in for just 2 weeks, I tell people lots of humidification. I ask them not to go far away from town or sometimes stay in town while they have it in case there's an emergency, and then getting it out soon after. So I'm not a big proponent of stents. That being said, some disease needs stent, there's no question about it.
Okay, the second question would be, when the patient does have the stent in for 2 weeks, can you feel it? Does the patient say they can feel that stent? Is it aggravating or?
Yeah, if you see, it's funny because you all are on these websites, so I can share stories amongst yourselves. I can't do that. So I'll get all this information where people say, how's she doing? How are they doing? And I say, I can't tell you. It's all hit by friend. So feel free later on to ask the people. Now, those stents that we're talking about are stents that you breathe through, and they're very short. A lot of people have got stents in that Dr. Chris showed earlier that are completely obstructive. In other words, you actually close them completely, or they're like an Eliashar stent, which is like a big, what do you call it, lipstick, that you can't breathe around. That's a very different situation.
Okay.
This is a stent that's basically the same size as your native airway. It's very short, and it's not obstructing your breathing. You want people to breathe up through there so they have no tracheotomy while it's in place.
Okay. And the last question,
You
the
go.
steroid injections, what type of steroid do you use? There's different types, right?
Yeah, so I think usually it's either Depo-Medrol or Kenalog, and I tend to use Depo-Medrol. I don't know if there's great evidence to suggest one's better than the other. Alex, do you have any comments about the type of steroids? usually 40 milligrams per cc, and try to inject about 2 cc's. I use a 25 gauge needle, which is a relatively small needle. And it's critical that ability to, people say, like, why are you all having fewer dilations than what I've had or what other surgeons have had? I think the technique of that injection is really critical. The needle's got to go in, but not go in too deep. If it goes in too deep, first of all, you might go right through the stenosis and just inject it into air. Or you might start injecting the cartilages, which is not what you want. But if you go too superficial, then it's just going to, come back at you. You have to put in just enough so it really deposits itself directly in the epithelium and stays there for a long period of time. Other people say, well, why do you do the steroid first? Why don't you do the steroid afterwards? After you make a cut or after you dilate, you've kind of made a little bit of a rip. And so therefore, when you inject over here, it just comes out over there. It doesn't stay in place. So I try to inject first also. The last question is, why make those cuts at all? Why not just dilate? And the reason I tell people is, we're trying to be as atraumatic or as least traumatic as possible. And if you tell the body, I'm going to open up this narrowing, but I want you to open here, I want you to open there and there. It's a very different type of appearance afterwards than when you just let the body kind of rip things apart. So that's the reason for those small incisions. Those small incisions are very small. They're a couple millimeters, but it really tells the body, it directs it where you want it to open.
So if I have some involvement in that first tracheal ring also with the subglottic, can you still do pattern and return?
Well, I'll tell you, it's pretty early days, and I think we really need to get the procedures perfected for patients who've got relatively isolated disease. And the question is, in 10 years, if somebody's got tracheal involvement or glottic involvement, will they